Good morning, everyone. We're going to get started, so we have lots of time for the talk and then questions and answers. I'm Adam Myers, co-director of the Health and the Public Interest Program with Dr. Adrian Fu Berman, who is also here. And we're pleased to be bringing you this seminar this afternoon by Neal Barnard, who will be introduced to you momentarily by Yoretzi. And we're going to say a couple words about the program and then about the introduction, and then we'll get rolling. The Health and the Public Interest Program is a program that emphasizes the social determinants of health, pharmaceutical marketing practices, ethnicity, culture, all of those other things besides medicine. And if you're interested in our program, you can go to our website, which is hapi@georgetown.edu, and it looks like Elizabeth is typing it into the chat. We welcome inquiries about the program from interested parties. So I want to tell you a little bit about how we're going to run this program today, because it's going to be a big audience, and we want to make sure that we have everything run smoothly. So Yoretzi Polanco is going to do the intro, followed by 45 minutes of the seminar by Dr. Barnard, and then we'll take questions and answers. We're going to keep people muted during the seminar because there's going to be a big audience, and then during the Q&A session, Yoretzi will first get questions from seminar registered students, followed by the more general audience. So she'll be moderating that whole thing and making sure that we get as many questions in as we can. You're also free to put things in the chat at any point. And I'm looking forward to this. So I'll turn it over post haste to Yoretzi.
Thank you, Dr. Myers. Thank you, Dr. Neal Barnard, for being here in this audience. So I will introduce him. Dr. Neal Barnard is a medical doctor, FACC, and also an adjunct professor of medicine at the George Washington University's Medicine in Washington, D.C. And he is the president of the Physicians Committee for Responsible Medicine. He has led numerous research studies investigating the effects of diet on diabetes, body weight, hormonal symptoms, and chronic pain, including a groundbreaking study of dietary interventions in type 2 diabetes, funded by the National Institutes of Health, that paved the way for viewing type 2 diabetes as a potentially reversible condition for many patients. Dr. Barnard has authored more than 100 scientific publications and 20 books for medical and lay readers, and is the editor-in-chief of the Nutrition Guide for Clinicians, a textbook made available to all U.S. medical students. And as a president of the Physicians Committee, he has led programs advocating for preventive medicine, good nutrition, higher ethical standards in research. His research contributed to the acceptance of plant-based diets and the dietary guidelines of Americans, and in 2015, he was named a fellow of the American College of Cardiology. In 2016, he founded the Barnard Medical Center in Washington, D.C. as a model for making nutrition a routine for all medical care. And he's working with the Medical Society of the District of Columbia and the American Medical Association. Dr. Barnard has authored key resolutions, now part of AMA policy, calling for new focus on prevention and nutrition in federal policies and in a medical practice. In 2018, he received the Medical Society of the District of Columbia Distinguished Service Award, and he has hosted 4 PBS television programs on nutrition and health. He's originally from Fargo, North Dakota, and he received his MD degree at George Washington University School of Medicine and completed his residency at the same institution. And he practiced at St. Vincent's Hospital, New York, before returning to Washington to found the Physicians Committee. And a fun fact about Dr. Neal Barnard is that he's actually a part of a band called Carbon Works. So if you are very interested in his music, you can, there's a website for Carbon Works. And without further ado, Dr. Neal Barnard.
Well, thank you, Yoretzi, for that lovely introduction. By one other biographical thing I might mention is that growing up in Fargo, that's cattle country, and my father, grandfather, uncles, as pretty much as far back as I can trace, we're all busily raising cattle. And my dad didn't like it, and he left the cattle business, and he went to medical school, and he was the diabetes expert for Fargo and all of Eastern North Dakota. And he got home from work each day about 6 or 6:30, and he'd set down his black bag. And I never once heard my father say that anybody with diabetes ever got better. And he never walked in the front door and said, wow, here's a person that had diabetes for 3 years and now it's gone thanks to the work that we did. It never happened because that wasn't the expectation. Their expectation was that they could slow down the damage of the disease, make the heart attacks and cardiovascular damage occur later rather than earlier, make your kidneys last a little bit longer, hopefully prevent the amputations and things like that. But when I was an intern at GW, I got to say things hadn't changed a whole lot. We were still trying to fight what was, for many patients, a losing game. So against that rather dismal scenario, we can have a much more optimistic vista, and that's what I'd like to share with you today, because it's thinking beyond the prescription pad to what actually caused these diseases in the first place, seeing how I can intervene in a perhaps more assertive way that really empowers patients and gets them well to the extent that we can. So with that introduction, let me share my screen, if I may. Okay. From my standpoint, the world changed in 1990. That was the year that Dr. Dean Ornish published a really amazing study. He wanted to see not if we could prevent heart attacks, but if we could reverse heart disease. So that ugly looking artery at the bottom that's got atherosclerosis narrowing it, he wanted to know, could I make it look more like that healthy artery at the top? And so he brought in people who had heart disease. And to everybody's surprise, he didn't say, let's have surgery or let me give you more medications. What he said was vegetarian foods, because they don't have, plants don't have cholesterol. They don't have animal fat. A half-hour walk every day, manage stress, which is why nobody at Georgetown was in this study, and avoid tobacco. And that was the whole program. And after a year, the results were really quite surprising. The average person had lost 22 pounds. Their total and LDL cholesterol, that's bad cholesterol, dropped to the kind of degree that you would see with statin drugs. But this was done with beans and asparagus, just simple foods. But what really made the headlines was everyone had an angiogram, which is an X-ray of the heart. I'll show you an example in a minute. You could see the narrowed arteries doing something that arteries just didn't do, which was they were healing, they were reopening, allowing more blood to get through the heart, and the chest pain was gone and people were feeling just terrific. In other words, it looked like coronary artery disease was a reversible condition. So here's why. Let me kind of just back up and give you a little bit more of the rationale. These are the products that I grew up on, and maybe you did too. Animal products. The middle column is cholesterol. The right-hand column is saturated fat. Saturated fat is bad fat. If you could look at it in a jar, it's waxy, it's solid, it's like lard. It's not a pourable liquid. Saturated fat causes your body to make cholesterol, and the particles of cholesterol irritate your artery walls and cause them to, for all intents and purposes, to form what are almost like scars. We call them atherosclerotic plaques, and they narrow the artery flow, and they eventually rupture and cause a heart attack. You don't want that. Okay, so here's what got Dean Ornish all hot about plant foods, is they don't have any cholesterol. That's a cool thing, and they have almost no saturated fat. So he said, don't eat the things at the top, eat the stuff at the bottom. Let's see what happens. And there were a few surprises here. One is salmon, which, oh, wait a minute, I thought that was a no cholesterol food. Looks almost as bad as beef, doesn't it? And of course, cheese, you knew it was true. Loaded with saturated fat. If it were any worse, it'd be Vaseline. But we all kind of love cheese, and that's kind of propels us to the emergency room. Okay, so let me share with you an angiogram. This was this patient was actually a doctor himself, and that part that I bracketed in white is a diseased artery. It should look like a clear, nice tube, but it's all crinkly. Those are plaques in the wall narrowing it. This person could not be stented because stents were insufficient. The disease process was too extensive, and he couldn't tolerate statin drugs to lower his cholesterol. So he went on basically an Ornish program. Let me do it by diet. And let me show you, here's the final result. And if the little photo strip is getting in the way on the right-hand side, let me encourage you to just minimize that or drag it out of the way, because I want you to see, after 32 months, that artery was effectively healed. And we knew that your skin heals from a cut or your bones will heal from a fracture, but arteries healing? Yeah, apparently the answer is yeah. So my research team, I was at the time, I was running a clinic at GW. I called up Dr. Ornish. I said, okay, people will believe this. They'll believe that this works, but they will also say that it's so rigid. Nobody's going to follow this program. Nobody's going to ever want to do it. He said, well, can we study that question? So I flew out to California and I interviewed every participant in the research study, in the control group and the intervention group, to ask how they liked the diet and how they liked their other diets if they were on the control group. And we published the findings back in 1992. And the bottom line is that any kind of diet change does require work. And it requires a couple of weeks to get used to it. But we couldn't find we couldn't find that his diet was in any way more demanding for the patients than any other diet. And there was one participant who was kind of seething with rage in the course of my interview. I was asking him about, how did you feel? How long did it take you used to the diet? And finally, I just said to him, I can see there's something else you want to tell me. You've got something on your mind. And he said, absolutely. I want to tell you something. I had so many doctors diagnose me with heart disease, talk to me about the fact I might need a bypass, costing tens of thousands of dollars. They wanted to put me on drugs, and not one of them ever told me that I could maybe do something myself based on my own choices for diet and lifestyle. I said, well, this wasn't really very well known at the time. But anyway, he was saying, look, you should be studying this kind of thing. You should be empowering your patients. And I thought, okay, let me make note of what you're saying. Because a lot of doctors at that time had this idea, patients are lazy. They just want to pop a pill. They don't want to make any changes. Nobody will do it. And I started to think much more broadly about what diet could do. So I get back to Washington. I round up my team. And I say, I want to do a study, but not for people who have heart disease necessarily, just people who want to lose some weight, reasonably healthy people. We brought in 64 women, all overweight, all past the age of menopause, and all feeling kind of stuck. And half of them went on a conventional healthy diet called the National Cholesterol Education Program diet. The other half went on effectively an Ornish type diet. It was no animal products, so vegan diet and low fat. We asked our patients not to change their exercise because we wanted to isolate diet's effect, and it lasted 14 weeks. And we invited people to make their meals from fruits and grains and legumes and vegetables, and they were scandalized because we were going to tell them they could eat pancakes and oatmeal and things that they thought would make them balloon out with calories. They could eat linguine with no limits on carbohydrates. And somebody discovered that even Twizzlers are vegan. So not that I'm recommending this, but they thought this is way too liberal of a diet. What are you doing to us? But after 14 weeks, the vegan group lost almost 13 pounds. The control group lost about 8 pounds. And after 2 years, the control group put the weight back on, but the plant-based group never did. And it was a qualitative shift that led them to kind of a one-way street for a healthier body weight. Okay, so then in 2003, the National Institutes of Health said, okay, if you're so smart, let's try to apply this to type 2 diabetes. And what we wanted to do was a diet trial where we compared a portion-controlled diet versus a plant-based diet. Now, when I say a portion-controlled diet, this is pretty much what doctors and dietitians were prescribing all the time then. And to a degree today, many of them still say you got to cut calories if you want to lose weight. And you've got to keep carbohydrate from getting too high. And you've got to limit bad fats. But in the plant-based diet, we didn't say that. We didn't say you have to limit calories at all. You can eat as much as you want, no limit on portions, and no limit on carbohydrate. Instead, we're going to focus on the type of food you choose from. Forget the animal products, minimize oils, and favor low glycemic index foods. That means foods that don't spike your blood sugar. So we're not going to eat sugary foods and say white bread because that'll spike your blood sugar. But you can eat whole grain bread or rye bread or pumpernickel bread or beans in unlimited quantities. to cut to the chase, the measure that we use for how a person's doing with diabetes is something called hemoglobin A1C. And if a person has diabetes, you want it to be below 7. And so the control group, the portion control group did pretty well. They dropped about 0.4. But the people on the plant-based diet dropped 3 times more, about a little bit more than 1.2 absolute percentage points, which is, if you had a pill that did that, that's like the greatest diabetes pill ever. And this was just done with diet changes. No exercise, no portion control, no limit on carbs, nothing. And let me just briefly describe a man who came in to this study. He was 35. He had diabetes for 4 years. And he said, I'm in trouble. He had extra body weight. He had high cholesterol level. He had erectile dysfunction. And his grandmother had diabetes. His grandfather had diabetes. His father died at 30. And he said, if I don't get under better control, I'm going to lose my vision or have an amputation or end up on dialysis or something I don't want. So he joined the research study. His baseline weight was 276 pounds, A1C 9.5. You want it below 7, 9.5 is what doctors would call poor control. His total and LDL cholesterol were high, and he had erectile dysfunction. So what we asked him to do, because he was randomized to the vegan group, was no animal products, minimize oils, favor low GI foods. That's the whole deal. He says, easy, I can do it. I said, well, what do you mean easy? Why is this easy? People think of a vegan diet as meaning that you have to acquire a taste for folk music and wear tie-dyed clothes and, whatever. He said, no, this is easy. Because when he had first seen a dietitian for his diabetes, they said, here's your 1,500 calorie diet. He said, well, I'm a big man, 1,500 calories, man. You make me eat that way. I'm going to try to eat the sofa. I can't live that way. But we let him eat spaghetti, just, instead of meat sauce, had tomato sauce on it. He said, I can do that. So 3 months later, he had lost, 25 pounds. His A1C was down to 7.1. His erectile dysfunction was in remission. He said, okay, there's something to this. Let's keep going. At 14 months, he was now down not quite 60 pounds. His A1C was down to 5.3. His lipids were better and his erectile dysfunction was still in remission. But the reason I'm showing you this is 5.3. That's a normal A1C. That's not diabetes. That's not pre-diabetes. That's totally normal. So I was ready, when I got his lab slip, I was ready to call up my dad and say, Dad, have you ever seen a man who had diabetes for 4 years on medication, come off all his medication, have a normal A1C? The answer is, we never thought that diabetes was reversible at all. And now here was this case where the man clearly didn't have diabetes anymore. So that was extremely controversial at the time because people said, well, he's got it, you just can't detect it. But now we have come to view diabetes as a reversible condition. Don't get me wrong, Velveeta is right around the corner and you can get diabetes back. And there are all kinds of addicting foods and companies that want to addict you to them. So I don't mean to say that life is necessarily simple, but diabetes is indeed reversible. So let me just walk you through the model that has come forward. And let me, if you're texting somebody or anything, let me have your full attention for the next 90 seconds. So I want to show you the cause of type 2 diabetes, because doctors get this wrong and patients don't understand this. Okay, this is a muscle cell. This purple blob is a muscle cell, muscle in your shoulder, in your thigh or something. And muscles run on glucose. It's a simple sugar, comes from food. It is the gasoline for your muscles. But the problem is that these glucose molecules cannot get into the muscle. They can't get through the membrane. The membrane won't let them in. So there are little channels that are closed, and you need this key called insulin. The insulin is made in your pancreas. It's right behind your belly button. The insulin goes out into the blood. It attaches to the surface of the cell. And when it does, that insulin is a key. It opens up these little doors and lets the glucose in. Okay? So the pancreas makes insulin. It opens the door. Here's the problem. I grew up in North Dakota. That's my dinner. That's my lunch. That's my breakfast. I mean, all kinds of fatty stuff, as are people in Baltimore. and Philadelphia and New York and LA and Washington and everywhere else. These are dietary staples for us. And yes, there's a lot of fat in all of them. Fatty foods contribute fat to the interior of muscle cells. You can't feel this. This is not fat under your waistline, but through magnetic resonance spectroscopy, I can scan your body. And I can tell you how much intramyocellular lipid you have accumulated. That's fat inside muscle cells. If I look at your liver, same thing. The fattier the foods are that you eat, the more fat that builds up inside your muscle and liver cells. And that's what stops insulin from working. That is the cause of insulin resistance. Okay. So now the person whose insulin is working fine, their insulin is not working at all anymore. Their blood sugar goes up and they're avoiding carbohydrates and sugar and so forth, thinking that's the answer. But the answer is to get the fat out of the cell. So on a plant-based diet, there's no animal fat at all. And if I keep oils really low, the fat dissipates. And then insulin starts working. And the glucose comes out of the blood, and suddenly your A1C of 9.5 starts dropping to 7.1 or to 5.3, and your diabetes goes away. So what we're tackling here is the cause. The doctor never told the patient this because the doctor hadn't read the studies. I'm going to walk you through them. Let's go back. Okay, just a little aside in the science. Yale University, 1996. This is Michael Roden working with Jerry Schulman and Kit Peterson. These are the most respected endocrinologists in the world. They brought in 9 people to start. These are healthy people, skinny people, don't have diabetes. They put an IV in their vein, and they gave them a lipid infusion. They put fat into their veins. So fat is going into their bloodstream. And what they showed is that their insulin sensitivity, the cell's ability to handle glucose, tanks, not within weeks, not within days, but just within hours. So you put fat into your system, your insulin gets disabled. Okay, so Michael Roden, he's now over in Germany. He brings in a new group of people, and he says, let me do this not with an infusion. I'm going to do this with a meal. I'm going to give you one meal that's got a lot of fat in it, and it's palm oil. It's a fair amount of fat, but it's about the amount that a person might eat in the course of a day in this fatty meal. And what he showed is that your insulin sensitivity tanks after a single meal. Now, palm oil is bad fat. I hope you don't eat it because it's very saturated. So he says, let's try canola oil. That's monounsaturated. Well, a little bit better, but more or less the same story. So with everybody who comes in here to our medical center, the Barnard Medical Center here, we're on Wisconsin Avenue, everybody who comes in with diabetes, we let them know that they did not get it from eating fruit, from eating bread or potatoes or sugar. They got that disease from fat buildup in their muscle and liver cells. And if we tailor a diet to get the fat out, then they can improve that disease. They might reduce their medicines. They might get off them completely, and the disease might go away. And that's always our goal. Okay, let me shift gears now. And a little bit later, I'll tell you how we walk into this diet, because there's a kind of a certain way that you want to make it simple for people. But first, let me talk about some other applications. We talked about the insulin hormone. I found myself taking an interest in, can I control other hormones with disease, with diet changes? And let me just walk you through this. I was sitting here at this desk and my phone rang, and it was a young woman who had cramps. And many women have menstrual cramps, but for maybe 1 in 10, they are just off the scale. I can't get to work today type bad. And that was her situation. She said, I've got a business meeting. I got to get on a plane, but I can hardly get out of bed. And she wanted some heavy duty painkillers. And that's why she called. And I said, okay, I'm going to give you some painkillers for today and painkillers for tomorrow. And we're going to help you to get through your life. But what's going to stop this from happening again next month? And I started to reflect on what menstrual cramps are. I just want to walk you through this because there's a lesson here. This is the uterus in the middle of your screen, and off to the side, you see the ovaries, and they're connected by the fallopian tubes. And in the very middle of your screen, that little pink line there, that's the endometrium. That's the little lining inside the uterus that every month it thickens up in anticipation of pregnancy. That's where the little embryo implants. So many women have what we call primary dysmenorrhea. They hurt, at the end of every month. And our belief is that what's happening is they got too much estrogen in their blood. That's causing too much thickening of that endometrial lining. At the end of the month, it breaks up and it releases prostaglandins that cause a lot of crampy pain. And there's another possibility. The other possibility is that you have endometrial tissue outside the uterus. Those little raisins you see, those are endometrial cells. Instead of lining the uterus, they're implanted outside. And that's endometriosis. They grow, they swell, they bleed, they hurt like crazy. Okay. So I figured, as she's talking to me on the phone, chances are she had one of these two conditions. They are both estrogen driven. Now, it turns out that researchers at Tufts University had done a study where they brought 48 women during their reproductive years into their metabolic ward. They threw away the key and nobody could go out to McDonald's. And they tried different diets. Each diet was about 2.5 months long. Cutting fat or increasing fiber. And they're not thinking menstrual cramps. They're thinking breast cancer. What they wanted to see is, can I reduce estrogen subfractions in a woman's bloodstream? Because if I can reduce the amount of estradiol that's coursing through your blood, I can reduce your likelihood of getting breast cancer in the decades to come. And what they found was just reducing fat alone. You could reduce estrogen subfractions. You could reduce the amount of estrogens in a woman's blood. Estradiol is the big one for a woman in her reproductive years. And just by increasing fiber, you could do the same thing. So this is all going through my mind. The young woman's telling me she's hurting. I'm writing her a prescription for 2 days of painkillers. But I said, let's do one other thing. Would you want to do this with me? Let's do an experiment. For the next month, no animal products at all, and minimize oils. What I just did is I made sure that everything that went into her mouth would have fiber in it. This is the way you maximize fiber, and there's not much fat. 4 weeks later, she called me back and she said, thank you for helping me out. I was able to get to my meeting. Everything is great. But the reason I'm calling you now is I got my period today. And I got nothing. Nothing. No symptoms whatsoever. And I said, this is good. Let's keep going. Let's see what happens. So month after month, she was fine unless she would modify the diet. So I thought, okay, that's important. So I called up Tony Shalley at Georgetown in the Department of OBGYN at the time. And I said, Tony, we need to do a randomized trial. And so we brought in women who had cramps, and half of them went on the diet. Half of them went on a placebo pill, a supplement. It's really a placebo. After 2 cycles or 2 months, they swapped. The diet people got the supplement and vice versa. And in a nutshell, it worked. We found the pain intensity was diminished. Pain duration was diminished. PMS symptoms like bloating and water retention or moodiness, all these things improved. Now, different patients had or participants had a different effect. But what we realized is that from the doctor, you hand over to the patient control over your own hormones and a degree of understanding of how they work, and let them apply it and just see how they want to do. After this happened, I heard the story of this young woman named KL. She grew up in Louisiana. She was in the Air Force, and she got a trip to Iraq in 2003, courtesy of the US government. And when you're working in a war zone and you're building military bases, and this is what she was doing, and when you eat only what the government gives you, you don't gain very much weight. And at the end of her tour of duty, the government sent her back home, and her family said, oh, I'm so glad you're back. Let's make up for all the stuff that you weren't able to eat while you were over in Iraq. So they really focused on the family's favorite, lots of cheese stuff. Cheese this, cheese that. In fact, one of her friends for her birthday gave her a carton of 48 packs of mac and cheese, which she ate every day for 48 days. I'm not making this up. And she gained weight. But she also developed pain, cyclical pain, that ended up eventually being pain every day of the month. And the doctor diagnosed endometriosis. Explained to her that you're going to have pain, you're going to likely be infertile because of the damage to your ovaries and fallopian tubes. She said, well, I don't really want any of this. What can we do? Painkillers were not very effective. And if you know anyone with endometriosis, they are often misdiagnosed. They are often not treated with tremendous skill and competence. And well, anyway, let me continue the story. You can judge for yourself. The doctor said, you know, we'll try hormonal treatments, we'll try painkillers, and none of these were really knocking out her pain. So the doctor finally said, we have one other treatment, and that's a hysterectomy. Because if we just remove your reproductive equipment, you're not going to have any pain anymore. But Catherine was 27. She and her husband were newlyweds, and she did not like the idea of a hysterectomy at that point. She wanted to have a family. But she realized she wasn't getting any better, and so eventually she acceded to the recommendation. And they scheduled the hysterectomy for 6 weeks later. They couldn't do it sooner. And in that interval, she saw a practitioner who had heard about our work and said, let's try a diet change. And she said, give me anything. So she eliminated animal products, kept oils really low. She felt dramatically better, but not fully better. She was maybe 85% better. And so when the day for the hysterectomy arrived, she thought, I've still got some pain. So I'm just going to go and have the damn thing done. I'm just going to have the surgery and be done with it. So she went to the hospital, and the doctor anesthetized her. And an hour later, she woke up. She's in the recovery room looking at the ceiling, feels a hand on her shoulder. It's the doctor saying, Catherine, I need to tell you, I opened you up. I looked inside. And to my surprise, your endometriosis is virtually gone. And I didn't take out your uterus. I didn't do the hysterectomy because you don't need it. But I discovered why you had some residual pain is that you have scarring where the endometriosis used to be. And the scars caused adhesions, and you're feeling that every day. And all I did was I freed up those adhesions. I think that's all you need. I think you're going to be better. But I can't explain why the endometriosis went away. And her mother was in the recovery room with her, and her mother said, well, doctor, she went vegan. And the doctor said, stop it. Endometriosis isn't caused by your diet, and a diet change won't make it go away. I think this is really just a miracle. So that's probably written in her chart, miraculous healing. Now, I'm going to praise that doctor because he did not do a surgery that she didn't need, which is good. But he had not cottoned on to the fact that diet affects estrogens. And endometriosis is a strongly estrogen-driven disease. And she had, without, I guess, anybody thinking about it, moderated her estrogen activity, we believe, causing the disease remission. And this is something that any patient can at least apply. It may not work for everybody, but it's a darn good thing to try. So she lost a lot of weight. She got her energy back, felt dramatically better. She was not infertile, as it turned out. She's got 3 kids. And she got some attitude. It said, well, women need to know about this. So she became a Food for Life instructor and teaches other women how to take advantage of what foods can do for them. Okay, I mentioned cheese, and you might ask, cheese? What's that have to do with hormones? Well, on every dairy farm in the world, cows only give milk if they have been impregnated and have given birth. And so this is not done with great delicacy or respect, but the cows are artificially inseminated through a rather creepy technique I won't tell you about. At birth, their calves are taken away, and then the farmers capture the milk and send it off to Safeway. They are milked during much of their pregnancy. They're impregnated every year, but they're also milked during the succeeding pregnancy. A pregnant cow makes estradiol, but it gets into the milk. So if you send a gallon of milk to a laboratory, they'll tell you it's got estradiol in it. And the dairy industry is aware of it. But they will say, well, compared to the amount that your body makes, it's not really very much. And that's true. But your body is already making all that you should be having. And to add extra can tip you into problems. So there is no such thing as hormone-free milk. These are hormones made by the cow. They're not injected. There are injectable hormones as well, but this is milk, no matter where it's from, always has estradiol in it. Okay, so a couple of years later, I wrote a book called Your Body in Balance, where I talked about using foods to modify hormones. And I started discussing how foods could also affect menopausal symptoms at the other end of the reproductive window. And a woman called me up and she said, I read your book and I did what you said in the book, and my menopausal symptoms, my hot flashes, disappeared within about 5 days. And I said, well, wait, I didn't promise that. I told you how the system works. I didn't think you'd get better that fast. What exactly did you do? And so she described how she had applied what she thought I had written. And so I took that to my clinical trials director, and we did a clinical trial on her dietary change. So I'm getting ahead of myself. Let me describe the science that led us to this point. If you go back to the 1980s, go back half a century ago, in Japan, only about 15% of women at menopause have had hot flashes, and they were pretty mild. But the diet at the time was mostly rice-based with virtually no dairy products at all. It was not a Velveeta diet. And some meat, but not a lot, some fish, but not astounding amounts. But the diet westernized to a great degree starting around that time. And by the early 2000s, hot flashes hit about 42% of women. Breast cancer rates went up, diabetes went up, everything that goes with the westernization got worse. So part of the credit for the low prevalence of hot flashes in the 1980s and before was soybeans. Soy was a big thing in the Japanese diet, and it still is. And soy isoflavones attach to estrogen receptors. And that's part of the reason that soy reduces breast cancer risk. But researchers also have assumed that soy might have an anti-hot flash effect. The other thing, though, is if you look around the world, there are other populations that follow grain-based diets and have beans, but they're not the same as in Japan. In Valladolid, which is about 2 hours west of Cancun in the Yucatan Peninsula of Mexico, there are many Mayan women, and researchers interviewed more than 100 of them and found that they didn't really talk about any kind of menopausal symptoms. You could ask them in detail about hot flashes and so forth, and they just don't have them. Now, they eat a grain, but the grain is not rice. The grain is corn. And they eat a bean, and it's not a soybean. That's not the big thing. It's black beans, big staple to this day in the Yucatan Peninsula. They eat lots of vegetables that gringos never heard of, like this is la chaya, and many, many others that are really healthy vegetables and big parts of their tradition. So our research team decided to do a randomized trial based on what this woman told me worked for her. We brought in 84 postmenopausal women, and it was a randomized study. And in the experimental group, we asked them to do a plant-based diet, minimize oils, and have a half cup of cooked soybeans every day. That was it. So the participants lost weight, about 8 pounds in 12 weeks, and their hot flashes dropped by about 88%. I'm talking about the moderate to severe hot flashes, the ones that wake you up at night and make you feel rotten. And that's a really good result. That's in the range where hormone replacement therapy gets you. But all the side effects in this case are good ones. And so not only did their vasomotor symptoms improve compared to the control group, but psychosocial symptoms like mood, physical symptoms like headaches, and sexual symptoms all improved. So many people in hearing of this will say, you will use soybeans. Aren't soybeans dangerous? Don't they cause cancer? And there is sort of this urban myth about that got started many years ago, but turns out to be the opposite, that high soy diets reduce cancer risk. Back in 2008, there was a meta-analysis at that time of 8 studies showing that a high soy intake led to, at that time, a 29% reduction in breast cancer risk. And a similar finding was brought forward in people who had breast cancer already. The red bar is mortality in women previously diagnosed with breast cancer. The yellow and green lines are women who were previously diagnosed with breast cancer, but now are on a high soy diet, soy milk or whatever. And their cancer mortality is reduced by about 25%. Okay, so anyway, soy doesn't cause cancer. It's optional. You don't have to have it, but it does reduce cancer risk and reduces mortality. And the reason we believe is that there are 2 different kinds of estrogen receptors. Estrogen receptor alpha is where estradiol attaches. and that's the gas pedal. So the estrogen your body makes, or that's in dairy, increases cancer risk. But the isoflavones in soy preferentially attach to estrogen receptor beta, which is sort of the brake on cancer and has other favorable effects. Okay. By the way, if you want to make soybeans, you want to give it a try. Edamame is great, but they're baby soybeans. So they're perfectly fine, but they don't have as much isoflavone as the mature soybeans do. So you go on Amazon and you buy Laura soybeans or some other brand, and you stick them in your Instant Pot, and you cook them for 40 minutes, and you've got soybeans. And you put them on a salad like pine nuts or something like that. It works fine. You can also cook them like any bean, just on the stove. And the amount that we used was a half a cup per day. And if you want to get fancy, for people, particularly people who travel a lot, you're not going to put your Instant Pot in your carry-on luggage. So after you cook them, you put them on a parchment-coated baking sheet, and you stick them in the oven for an hour. And then you season them up with salt or cayenne or whatever you want. And if they're nice and dry, and you put them in a Ziploc bag, you carry them anywhere you go. Or you can also just buy these online. There's a company called Laura that they'll send you pre-roasted soybeans. So they're a food, but they're like a medication. And you can use any soy product you want to. They all have isoflavones in them. But the reason we use mature soybeans is the amount that gives you a clinically significant amount is you don't need very much of the mature soybeans. If you did it with soy milk, you'd need to have 2 quarts of soy milk a day. So that, they're all fine, but that's the reason that we use the mature soybeans. Last thing, second to last thing, let me just mention a little bit about, very often patients say, well, and doctors say, this plant-based diet sounds so demanding. Why don't you tell people to do a Mediterranean diet? So we have put the Mediterranean diet to the test, and the Mediterranean diet the term was coined by Ansel Keys, who was a terrific researcher at the University of Minnesota and an honest and very good man. And in Minnesota in February, anybody would rather leave there and go to southern Italy, and that's what he did. And he fell in love with a little town called Nicotera, and there they had, in the post-World War II period, a pretty modest diet of a lot of plants and not big steaks. And they weren't cooking in butter and that kind of thing. And they had a pretty low level of heart disease. Not as low as, say, Japan, but lower than the US by far. And of course, nowadays, everybody wants to live in southern Italy, and so they'll readily accept a Mediterranean diet, no matter what it is. But it really means plant foods, minimally processed, don't have pudding for dessert, have fresh fruit, don't use butter, use olive oil, some dairy, some eggs, some red meat, but not much. Wine is okay. That's the Mediterranean diet. So our team did a head-to-head trial of a Mediterranean diet versus a vegan diet for people who wanted to lose weight. It was a crossover design. So everybody did both diets, 16 weeks each. And we had a dietitian who practiced personally and believed in their respective diets, work with them. So they got lots of good coaching. And the results, first of all, with regard to weight, the Mediterranean diet really did not lead to substantial weight loss. The vegan diet causes quite significant weight loss. And then when people switched diets, the people who had been vegan and now went Mediterranean started putting weight back on, and they were really annoyed. The people who had been Mediterranean and now went vegan started losing weight. That's what you'd expect, because a plant-based diet is not calorie dense. It doesn't have a lot of fat in it, and so people tend to lose weight very readily. A Mediterranean diet, while it's a healthier type of fat, is still very calorie dense. Extra virgin olive oil has the same number of calories as lard, and that's the problem with it. So when it came to lipid lowering, same kind of thing. The Mediterranean diet does not cause cholesterol improvements to a substantial degree, whereas a plant-based diet really does. But let me say a word of praise for one thing the Mediterranean diet does, is it does seem to lower blood pressure, even better than a DASH diet. And I suspect, but cannot prove, that that's probably because of polyphenols in the extra virgin olive oil, which have a blood pressure lowering effect. So there, the Mediterranean diet turned out to be better when it came to blood pressure lowering. So the last thing just to cover real quick is how do you help a person or help yourself to try this kind of diet if you wanted to? And it starts by explaining what the diet is: fruits and grains and legumes and vegetables, and you should take vitamin B12 for healthy nerves and healthy blood. And I can tell you more about that if you'd like. But then we don't simply rely on an explanation, because logic plays virtually no role in human behavior. You know this is true. Turn on any television channel and you will recognize that logic just isn't a big determinant. And this is true for the first meal you make in the day. You don't build your diet based on logic. You build it based on culture, what you've eaten or what your family eats or what's advertised or what you're hooked on or whatever. And when doctors explain a healthy diet to a patient, let me show you the neurology of what transpires. The doctor explains to the patient that your cholesterol would fall if you follow a plant-based diet. And within the brain, that stimulates the ideatron, you know, the ideatron in the brain, to release ideas like, I should change my diet. But those ideas irritate the famiglia, which then triggers the don't do-atory gland to release endorphins. And suddenly your idea is totally snuffed out. You can't pay any attention to it anymore. And so doctors don't rely, or we don't rely on logic. What we rely on is simple rules and then the experience. Patient comes in, they want to reverse their diabetes. What should I do? And we show them how the fat builds up inside the cell. And then we say, here are the kinds of foods that just don't have much fat. Okay. So then our registered dietitian takes it from there. She sits down with the patient and the patient's reluctant spouse and says, okay, what do you eat now? Let's come up with breakfasts and lunches and dinners that work for you. And think about some things and come back in a week with a list of foods that you would really like. So your assignment for this week, just try out foods, see what you like. And so there's all kinds of choices. And the patients are thinking about them, and you've given them books and websites, and they're trying out all kinds of foods to see which ones they like. And if they like them, they go on their list. And if they don't like them, they don't go on their list. And if they like Italian cuisine, or they might like Chinese or Latin American cuisine, or they might like Chinese cuisine, or they might like Japanese restaurant, whatever it is, the kinds of places they eat, whether they cook or they don't cook, it's up to them what goes on the list. And if fast food is their thing, then what are their choices at a fast food restaurant? So then finally, they come back in. I say, Doc, I come up with this great list of foods that work for me. They're all vegan. You'll be so proud of me. Now, step 2 is just, let's eat those foods. For the next 3 weeks, we're going to do a test drive, and we're not going to eat any animal products at all. But you only have to do it for 3 weeks. I can do that, no problem. At the end of 3 weeks, they have started to achieve results that strike them as really noteworthy. Their glucose is coming down. They're starting to lose weight. Their digestion is better. Their gastroesophageal reflux is gone, or whatever. And plus, their tastes have changed. In a 3-week period of time, if you haven't had chicken wings, you find you don't really care anymore. And so the patient comes back after 3 weeks and says, I want to keep going with this. Let me just see how far I can get. So we give them an app, and the app is called the 21-Day Vegan Kickstart. You can use this app. It's in English and in Spanish, and it's free. It has no commercial sponsorship, but it gives them menus and recipes and cooking videos. And we have information for medical students and clinicians, also for free. It's called the Nutrition Guide for Clinicians. It's online, continuously updated. We have CME for doctors, dietitians, pharmacists, physician assistants. And every patient who leaves our clinic gets this little card. And you can hit this QR code right now if you want to. It brings you to a website called foodinstructions.org. And that gives them these little cute, inoffensive videos that last a couple of minutes that talk about what I just talked about in a way that they can share with their family and their friends and explain it to them. So everybody gets that. And my hope is that with this kind of program, first of all, it helps the patients a lot. Secondly, it helps the doctors a lot, because doctors these days don't want to be on an assembly line running a factory where they're handing out prescriptions to patients. This certainly helps the environment and it helps the animals that we share the planet with. But I think maybe the group that's helped the most is the next generation. Because if we can learn how foods affect our body, and if we can help our body to recover, we're not going to live forever, but we might live longer, and we might be able to keep our families together a little bit longer as well, and live better in the process. So I want to thank you very much for allowing me to share these observations with you. And if there are questions or comments or rejoinders or anything, I'd be more than happy to take them.
Thank you, Dr. Barnard, for the informative session. I'll go ahead and open up the floor to happy students first, or students in the seminar, and then we'll go to the general audience.
Would you like me to take them, or would you like to let me know which ones you want?
I can let you know. Emily,
sure.
do you have a question?
Yes, thank you. Thank you so much for taking the time to come and speak with us. This was really interesting. One thing we focus on in our program is sort of like bridging the gap between or identifying other socioeconomic factors when it comes to community health. So, for example, if we're dealing with maybe lower income communities or things like that, but we want to obviously bring them access to things like really healthy, local, less processed foods. I guess my question is kind of twofold. If one, you've had any experience trying to bring this type of information to low income communities and like how that has gone, and is it sort of an all or nothing type of thing? If say someone can't afford to do all of their meals this way, is kind of just a bit of replacement still enough to see opportunity and results and changes in their health overall?
Okay, first of all, I'm so glad you're in the program. Thank you. You're making the world a better place. Secondly, you've asked what's probably the most important question. In this city of Washington, if you look at the different wards in town, you see dramatic discrepancies in health, and these relate in part to food or things that we can address with food. So your question is a really, really good one. The question is, what can people afford? We did a study of exactly that question. We brought in 244 people. And half of them were put on the diet that I just described, the other half were not. And we tracked their food costs. And what we discovered is that people on the diet I described spend more money on fruits and vegetables and beans than they were spending before. But they don't spend any money on meat or dairy products or eggs. And when you net it out, they're saving about roughly 16% off their food costs, which adds up to about $500 a year. So the question, if your question is, how can people afford to do this? How can people afford not to do this? It's the most cost-effective thing. The second thing, you're not lining up at CVS for your metformin prescription as much. So your prescriptions for you and for your son and your daughter all go down. We did a study with Geico, the car insurance company, and showed that the absenteeism goes down, because you don't need to be at the emergency room so much and you're feeling better. So families do dramatically better. But there was a really frightening study that came out from the University of Connecticut, the Rudd Center. And they looked at marketing. And who do you think the fast food chains market to the most? It's disproportionately Black and Hispanic youth. And so who do they want to buy the bacon cheeseburger and all these kinds of things? And if you're in a neighborhood and the Popeyes is closer than the Safeway, is it your fault? So we have also done studies where we looked at race. And if anybody wants to suggest that the diet is something that one race or another is going to do better at, that it does not turn out to be the case at all. We find virtually identical changes across races in the improvements in A1C and everything else. So it's something that should happen to everybody. But let me blame the SNAP program a little bit, the Supplemental Nutrition Assistance Program, because I can be a SNAP retailer and you can come in with SNAP benefits. You say, I'm on a limited income, I need SNAP benefits. I can take your card and they're going to pay me just as much if I sell you candy, if I sell you Spam and bacon, as if I sell you organic produce or something like that. That's the way the system is set up. And if you complain about it, you say, why do we provide foods that we wouldn't have in a school lunch program, but we put them in a SNAP program? The government says, well, we don't want to take away people's choice. My feeling as a physician is, if the government is going to make food available, we should provide foods that we are proud of. the best foods for anybody who wants to get them for themselves and their families. And that's what we really should be doing. So anyway, the question you've asked is a really, really good one. And I think if we make this information available widely, people can choose for themselves. But this is going to be a good choice.
Thank you so much.
Sure.
Thank you, Emily. We have Margot next.
Thank you so much for your presentation. I only feel slightly better about my diet now, but it's helping me be more aware. I used to work a lot with the SNAP program and SNAP recipients. So I am very protective of the SNAP program. And I know that they have their like double up bucks initiative, which is, I think, great in theory, but it still gets to the problem of access, which I think is largely out of SNAP control. But that's not really necessarily related to the question. And my question being, when I worked on the SNAP program, I used to help with doing a nutrition curriculum to figure out how to get people to get the most out of their money, and then still have healthy meals. And I was just wondering, like, how do you go about spreading this information through nutrition education without being, or like having a condescending tone? Because I think a lot of times I had trouble trying to tell people how to eat, like suggest things when I know that like I can help make this, but there's still a time cost of like thinking through all of how to shop differently, how to prepare these meals differently, and how that's just like hard on top of like a lot of other things that low-income families are facing. So I'm just wondering, like, how do you go about nutrition education without being like condescending and trying to meet people where they're at?
Okay, well, if any part of you feels condescending at the time, just take that and set it aside. The person who's coming to you has certain goals that they're trying to reach. And that's what we're really talking about. So if a person comes to you and says, I have some health issues that I'd like to address, then the next question is just information about how do food choices influence those health goals. Now, for me as a doctor, that's what they come to us for. If somebody has a different role, maybe they're a culinary expert or something, it may be that health issues aren't what is on the table. But we simply explain what the facts are. And then if a person says to me, how can I really make it work? I'll give my very best advice. But if a person doesn't take that advice or they have trouble with it, you're never judgmental. Everybody who comes into our practice, you treat them like they are your next Olympic athlete. And if they fell down one day, that's all right. We're going to get up and we're going to do it. Everybody can succeed. But what we don't do is I never say, well, I'm just going to meet you where you're at. You probably can't do this all the way. So just do it now and then. To me, that's condescending, because it's not hard to eat spaghetti with tomato sauce. And to say to a patient, oh, you can't do it, is belittling. And if a patient comes in with a urinary tract infection, and I say, oh, you probably couldn't take the antibiotic 3 times a day, just take it once a day. That's all you could do. That's ridiculous. They can do it. But then it is their decision what they wish to do. And however they interpret it, they are welcome to come back and we'll continue the discussion. Does that help? You're muted, I think. Or maybe I am.
Can you hear me?
Oh, there we are.
Okay, yeah, I think sort of flipping that mentality of like believing in people is really helpful, because I think sometimes we get bogged down in just listening to people's stories and being like, yeah, this is hard. But I think having that mentality is helpful going forward. Thank you.
Yeah, well, people have learned all kinds of crazy things. They've learned that carbs are bad. So if you tell them you can eat rice again, they think you're lying to them, because everyone else told them that carbs are bad. So there's a lot of unlearning that has to happen. Plus, there are addictions that well up all the time. People can get hooked on all kinds of bad stuff, and we just take it seriously. But we're not judgmental. We're all in this together, and we help patients as much as we can.
Thank you. Kandai, you're up next.
Hi, Dr. Barnard. Thank you for your presentation. I was wondering about some volunteers and the long-term effects of this, because it's easy to follow a diet for like a year or 16 weeks or 3 years, but also some people do experience a big change and then they want to go back. And so do you suggest that, do you have like a timeline of how long people should be doing this? How early can they start? For those who don't want to give up, the meat or the dairy products, what suggestions do you have for them? Because somebody might not want to be in a vegan diet. So how do you relate that to patients?
Yeah, when patients come in, we explain to them what causes their disease. For example, it's a very common thing is the person has a high cholesterol level. And so we explain to them that cholesterol is in animal products, and the saturated fat in animal products increases your cholesterol. And so the treatment for a high cholesterol level is to not eat the things that are causing the problem. Now, the patient might say, as you're saying, well, but I want to eat the foods that cause the problem. Solve my problem, but I'm going to continue to cause it. So what do you do? And you can at that point say, well, keep eating the bad foods, but there are companies that will sell you drugs that will try to counteract the effect of your not healthy diet. And that's the way most medicine is practiced, that most doctors now don't counsel patients on a healthy diet, and they use a statin to lower cholesterol. They'll use an antihypertensive to try to counteract the blood pressure increasing cost parts of the diet. And they will now use Wegovy and Ozempic to try to counteract the appetite, which has to do also with unfortunate dietary choices. So patients are free to do what they want to, but we don't typically see people have this reaction. After they've had a chance to see how they feel on a healthy diet, they typically want to just continue. It's very much like when a patient quits smoking. Nobody really wants to quit smoking because they like cigarettes if they're a smoker, but they know they're going to die, and so they quit. And after about a month, they're really glad they quit. And they typically don't say, well, how often can I smoke now? Because I really miss it. They're usually just glad, and that's kind of all there is to it. But they'll stumble into it. And so you have to kind of stick with them during moments of hesitancy. And diet is the same kind of way. By the way, the other thing is we have groups where we get together with everybody every week. And they swap recipes, and they feel really supported, and they're not alone at all, and their family members join them. So healthy eating gets to be a really fun thing for them. So we don't see too many people deciding that pork chop really looked good anymore. But that's a great question. Thank you for raising it.
Maggie?
Yeah, thank you again, echoing what everyone else has been saying. This has been super informative. I was wondering if you had done any work working with like Native American reservations, because I know diabetes rates are often pretty high there because of the reliance on government food subsidies, and there's a lot of issues with food deserts and access to food. And I was wondering how kind of tips regarding this diet might possibly be able to be implemented there.
It's funny you'd ask that. I wrote a book a million years ago about diabetes after our NIH research was done. And I got a call from a Native American radio station called Native America Calling. And they asked me if I'd be on their show because they said, just what you said, diabetes is a big problem in Indian country, is the way they put it. Would I come on and talk about our program? So I'm describing this plant-based diet, and a caller to the radio station said, Dr. Barnard, what you're talking about is you're talking about a Native American tradition called the Three Sisters. And the host said, tell us about the Three Sisters. She says it's corn and beans and squash. And I had never heard of this. And she and the other people were talking about, everybody knows about the Three Sisters. This is the Native American tradition of the most healthful foods. And so after the show, I started Googling Three Sisters, and I caught a plane and I went to Albuquerque, and I rented a car and drove out to Window Rock, Arizona, which is the capital of the Navajo Nation. And I met for about an hour with the Navajo. There's a thing called the Special Diabetes Program there. And I said, explain to me about Native American foods and Navajo foods. And they were really patient and helped me understand. And they said, you can't leave. Explain to us about your NIH research. And so we hit it off. We made a partnership. And we have since that time done many, many programs, particularly with the Navajo Nation, and have seen just dramatic results. Because what you said is true. This is an agrarian culture that was effectively enslaved by the US government, and eventually returned to their homelands, but they brought with them government cheese and junk, and their lives were totally disrupted. But they can go back to these things. And we're now working with a man named, I don't know if you know Jonathan Nez. He was the vice president and then president of the Navajo Nation. He now works with us to promote exactly a plant-based diet for exactly the reasons that you have given. And finding exactly the same issues is, okay, we've now gotten kind of hooked on, Whataburger, and we've gotten hooked on cheese or alcohol, or all the issues that, thank you very much, Europeans, for bringing into North America. Those are real issues that we're all kind of dealing with now. But yes, the answer to your question is, I fully embrace what you're saying. We need to spread these, and not just to Native Americans, but to everybody.
Thank you. Jasmine, did you have your hand up?
Hi, yes. So I was wondering, how do we get, and I know some states have included waivers for nutrition services to be included under Medicaid, but for like nutritional like prescription to be covered by insurance. Just wondering your thoughts there and if you have done any work on that line.
One simple place to start is right now Medicare, which is the one for older folks, so to speak. It will not pay for one single dietetic visit for a person who's got weight issues and wants to lose weight. You think, wait a minute, Medicare will pay for all the health issues that you got as a result of overweight, but it won't help you to solve the problem. And the answer is that's right. Medicare will not pay for one single. If you're pre-diabetic, it will not pay for an appointment. But once you fall into diabetes, then you could see the dietitian. So that's got to change. But we also have to make sure the dietitians who have very different kinds of expertise, that they know about what a healthy diet really is, and they have to be up to date about it. There are a lot of programs now using medically tailored meals that I think are worthy of exploration. My own prejudice is I use really simple, cheap stuff. I don't really deliver meals. I'd rather just say, there's the bean aisle at the store. There's where the lentils are in the little bag. Here's the rice, and here's how you boil it. Really cheap things. But I think we should explore these things, and we should kick the industry out. The dietary guidelines for Americans are being reformulated now. I hope you're all weighing in. Pay attention to this process. The dairy industry, the meat industry, the candy industry, the fisheries, the liquor industry, they're all bending arms in Washington about why their products should be part of federal guidelines. The federal government is nervous in the 2024 elections. Nobody wants to lose the pork farmers' vote. So all of these things are politicized. But the bottom line is our patients' health depend on simple, healthy foods. And whatever gets them in front of patients is a good thing.
Thank you, Dr. Barnard. I had one question as well. I was wondering about, you touched a little bit about how the group sessions are really helpful. I think a lot of times when people are going through like diabetes or something and they need a diet change, their family is very like not supportive of maybe the diet that they need to take. Have you seen any like isolation or just any other like mental health components also contributing to just kind of in a way of changing the diet in the beginning, but then them feeling better later?
Yeah, it really runs a whole range. There are some cases, sort of as you're describing, where the patient wants to lose weight and get better. And they come in and we prescribe a healthy diet, which may be at odds with what the rest of the family wants to eat or is used to, or is maybe even a little hooked on. So it's really good if somebody has a partner, spouse, whatever, bring them together so that we're all talking one language. 8 times out of 10, the partner will say, well, I'm with you, I'll support you. And eventually it starts to make sense to them too, and they want to go the same way. If there are kids in the household, bring them in. The kids can follow this diet too, and they do really well with it. And it's important for families to know that type 2 diabetes is not predominantly a genetic condition. There are genes that play a role, and you're not going to change those genes. The decisive part is the food habits that are passed down from grandpa to the next generation and the next generation. And to the extent that we can change those, everybody gets better. But we have to be patient with our family members. Nobody likes a real nudge. And their doctor, like me, is already enough of a nudge. And then they get their family members saying, I don't want to eat your favorite old meatloaf recipe anymore. And, we get all kinds of family issues tangled up here. But we support people a lot. We encourage family members to join in the meetings that we have together. And for the most part, people really work it out well. I'm working with a family now where the identified patient was one of the children, where she was gaining weight much faster than her peers. But the family all adopted the diet, and the one who's now lost the most weight is the father, who has embraced this diet, absolutely loves it, and is really supporting his family to do it together.
Thank you, Dr. Barnard. Is there any other? I'll open up the floor to any from other audience members as well. I think we have time for maybe 1 or 2 questions. I see Mitsu, if I'm saying that correctly.
Yes, thank you. I understand erectile dysfunction remission, but I think you mentioned that the soy and the estrogens had some effect on female sexual dysfunction or something. Could you explain that?
Yeah. When we use a questionnaire called the MenQual questionnaire, which is an online questionnaire, and as the women were going through our study, they reported significant changes in their sexual symptoms. And the questionnaire is not more sophisticated than that, and it's not longitudinal. So they report that they're feeling better. I presume that means less dyspareunia and less itching and those kinds of things. But menopause is real. It's the closure of the reproductive window. So it doesn't mean that you're going to be having sex in the same way when you're in your mid-50s as you were when you were in your mid-30s. Obviously there are things that women can do if they wish to remain sexually active. But I would be very surprised if soybeans are going to have a prolonged effect on some sexual symptoms. You didn't ask this, but for women who are interested, we do use the dietary method that I mentioned for hot flashes, vasomotor symptoms, instead of systemic HRT. And it works really, really well. And I recommend against systemic HRT. But a woman may add local hormones, just vaginal hormones, just for sexual functioning. And they're still, to an extent, absorbed, but the contribution to breast cancer is probably much less than if you're taking oral hormones. So that way they use some medication, but not a whole lot. Hope that answers your question. Great, thank you.
Thank you. We may have time for 1 quick question before we close, if there is any.
So if not, I just wanted to interject that we have another seminar on nutrition coming up on November 15 by Dr. Tom Sherman, who will address some of the issues around policies and industry practices that result in what we see on the shelves and in the government programs, et cetera. So it'll be highly complementary to today's talk, which I think although we weren't really talking about public health directly, it has enormous consequences in terms of the potential for improving public health. So I want to really thank you, Dr. Barnard, for this great presentation today, and Yaretsi for a great job moderating. Hope to see many of you back next week for a talk by Liza Vertinsky, who's going to talk about some things related to pharmaceutical development and practices by manufacturers that I think many of you who get to us through the Farmed Out listserv will appreciate. So great session today, and I look forward to another big audience next week.
Thank you so much, Neal. That was great.
Thank you.
Thank you for the invitation.
Thanks.
Take care, everyone.